with respect to the neoantigen study, we performed a phase 1/2 study looking at this novel approach where patients' tumors were sequenced and optimal mutations were identified through Gritstone's EDGE platform. And the top 20 neoantigens were chosen to introduce into both a prime vector, which is a ChAd or chimpanzee adenovirus vector, and a boost self-amplifying messenger RNA vector. So the same antigens going into the prime and then the heterologous boosts. And so the phase 1/2 study included patients with microsatellite stable colorectal cancer, gastroesophageal cancer, or non-small cell lung cancer who were eligible. And so we performed a dose escalation study where the ChAd dosing was held constant, and there was escalation of the SAM boosting for 3 doses, as well as concurrent IV administration of nivolumab, and in some of the higher dose cohorts, subcutaneous ipilimumab around the ejection site of the vaccine. And so overall, with regards to tolerability and safety, the strategy was tolerated well, as would be expected. Many of the toxicities that were seen could be attributed to, say, nivolumab, and at expected rates in terms of the autoimmunity toxicity profile. And specifically attributed to the vaccine was local irritation and pain for a day or two as typical, and also fever and other types of things along that nature that were addressed with antipyretics, and typically grade 1 or 2. And so overall, in terms of efficacy, looking at the 22 evaluable patients, evaluable by traditional RECIST response, and at any of the dose levels, including all the patients, we did see 1 complete response and 5 patients with stable disease. So for a total disease control rate of 27% in these pre-treated chemo-refractory patients. And so we also looked at, because of the sort of the difficulty in understanding that it does take some time to mount this response, the immune response, and that there may be some growth initially during that time where RECIST may not capture that. We also looked at circulating tumor DNA dynamics over time, and also immune RECIST to evaluate for a longer term benefit. And interestingly, and specifically for colorectal cancer patients that were microsatellite stable, we did see that 44% of the patients had dropping of the ctDNA as their ultimately their best response, and this correlated with evaluation and response ultimately and target shrinkage on scans, as well as longer term progression-free survival. And in addition to that, when looking at something that's quite encouraging, was that longer term progression-free survival, particularly by immune RECIST, survival at 12 months was about a quarter of the patients. So there is a sort of a plateau there that's encouraging, and in a disease type that, like microsatellite stability, colorectal cancer, where immunotherapy checkpoint blockade alone is really not that effective, this is promising and encouraging. And so the phase 2 cohorts continue to accrue, and also there are planned other studies for first-line maintenance colorectal cancer, and also adjuvant therapy in high-risk colorectal cancers having ctDNA positive disease. So this was the study looking at the neoantigen vaccine approach as a phase 1/2 study.